Okay, good evening all. Good evening all, good evening. So yes, let's make a start. Welcome to tonight's meeting, the Health and Social Care Policy Accountability Committee. My name is Councillor Natalia Perez and I chair this committee. Before we make a start, I have a few housekeeping points. By attending and participating at this meeting, you are consenting to being recorded. Please can officers and guests also introduce themselves when they first address the committee? If the fire alarm sounds, please leave the meeting in an orderly fashion by the staff fire exit, which is behind me to my right. Officers will direct you to the assembly point in Riverside Gardens. Before we move on to agenda item number 1, I would like to welcome Councillor Bollard to the committee. Welcome. Also, thank Councillor Alfonso for his contributions in the last couple of meetings, and also nice to see you, Councillor Kohn. And I also want to welcome Dr. Ayara. I found which, and I know your new role as Director of Public Health. So welcome. Thank you for joining us, and all other guests as well. Thank you very much for joining us this evening. So agenda item number 1, apologies for absent. Do we have any apologies? Okay, so we have apologies from Lucia Wellington and Victoria Bruno will be attending, is joining us via Zoom. Good evening, Victoria.
Hi there, can you hear me okay?
Thank you. Okay, so we note that. Agenda item number 2, are there any declarations of interest? No declarations of interest? Thank you. Agenda item number 3. Do we agree the minutes of the meeting held on the 8th of July 2025 as an accurate record? Great, thank you. Let's proceed then to agenda item number 4, Hammersmith and Fulham Health and Care Partnership Update. And Caroline, you're going to be leading on this. Welcome, Caroline.
Yes, good evening, Chair. It's Caroline Farrer. I'm the Managing Director of the Hammersmith and Fulham Health and Care Partnership, and I'm really pleased to be able to come and report on progress of the partnership this evening. So our introduction really covers the fact that a year ago we decided that we wanted to refresh our work plan as a partnership and reaffirm our commitment to working together. We've got a lot of high quality, resilient organisations and great people working together in the borough, but things, the macro environment, if you like, is very challenging. As we know, we're all challenged financially, and we have a highly fragmented NHS provider landscape. And then since then, we know that we are continually undergoing this process of restructure and realignment within the NHS commissioning responsibilities in both local, regional and national teams. But I think what we've brought for you this evening is how, when we get people working together on the ground, how our determination and ambition to overcome those challenges together can really be brought to best effect in terms of improving services for local people and the outcomes that they have in their lives as part of that. Our refreshed partnership and purpose and priorities are set out on the second slide. The two key areas that we agreed to work on were around integrating services. So that's how we get the right care to people at the right time that improves quality and outcomes and reduces overall costs to the system. And then creating health, which is about supporting communities to be more resilient with improved health and well-being to improve outcomes and again, reduce costs. So what we wanted to focus on this evening is on our integrated care priority and how we've worked together to make a difference for people with the most complex needs. Our development of the integrated community access point has given people in our borough, our frontline operational teams, a real focus for their energy. Our starting point, as you can see on, if I show you the next slide, is a very confusing map of services across multiple organisations. So our challenge is, how do we make best sense of this to make sure that people are getting the right assessment and then that the right plan is put in place for their care and support needs? So at that point, I'll hand over to Ian Jones.
Thank you. Hi, good evening. My name's Ian Jones. I'm Head of Clinical Services for Planned Care in Hammersmith and Fulham. My organisation is Central London Community Healthcare, and I'm in a very fortunate position in that I'm released 4 days a week to work with Donna and with Caroline and other partners around integration. As Caroline, so if you could go to the next slide, please. Sorry, if you can go back to... Yeah, back to that one. Thank you. So Caroline introduced this as the sort of the picture, the status quo, with multiple services and organisations involved in providing services for older people in Hammersmith and Fulham. And just to sort of break this down a little bit, the pale pink blocks are the sort of large traditional NHS community providers. So my host organisation, Central London Community Healthcare, is in there. We provide district nursing, for example, community matrons, host of other services. Also within those pink blocks are Central and North West London NHS Trust. They provide the sort of rapid response part of the nursing and also some packages around rehabilitation. So we've got multiple packages. The sort of darker brown colours are acute colleagues, where they provide services in the community. So in this example, it's Imperial providing a community respiratory team, community heart failure team, and a community diabetes team. And then the darker pink are our adult social care, London Borough of Hammersmith and Fulham. So essentially what we've got here is a kind of whole range of organisations providing services around older people. What we found in leading up to the ICAP model, which I'll talk about in a bit more detail, is the professionals and clinicians working within this system actually find it confusing themselves, and they're in the centre of this and working in it day to day. And we also picked up that those clinicians and professionals sometimes find it difficult to communicate, so particularly across organisations, but sometimes within organisations from team to team, the communication can be patchy. We've also picked up that referrers into this system find it quite difficult to navigate. And in my sort of day job, I often get calls from GPs who are main referrer to say, which bit of the pathway do I need to connect to? Because it's quite confusing. And I think most importantly for patients, this can be a very confusing landscape of services. And we have found cases where in one day, multiple services from multiple organisations have visited a patient's home or a resident's home in one afternoon. And what that means is the resident needs to tell their story several times. So in response to this, we've developed the Integrated Community Access Point, or the ICAP. So to put it really simply, this is an alliance of clinicians and professionals across multiple organisations who are coming together to work in an integrated way. It's almost as it's a little bit like the providers rearranging themselves and looking at how they work in order to be more responsive to the needs of our clients in the community. In doing so and in coming together, we've managed to break down some traditional organisational boundaries and barriers. So for instance, in the ICAP, with our professionals working together, it's negated the need for lengthy referrals, complex pathways referrals. We're able to just have a conversation amongst professionals and get the right team around the patients. We have definitely approached this with a sort of test and learn approach. I think when you've got multiple partners involved in a system and multiple professionals, you're never going to agree on everything from the outset. And I think in the workshops leading up to this, one thing that we were really clear on is that all partners agreed on the concept and that working together in an integrated way was the right thing to do. So we've had to create a very safe space for the people working within ICAP in order to have challenging conversations with each other, understand the different organisational cultures and different ways of working. We have prototyped the model in the South neighbourhood area, And as Caroline's mentioned at this meeting before, older people are a priority area in the South. We started in May, and we have brought together personnel from existing teams. We're not doing this with additional resource. We're doing it with the people already in the teams, and really good partnership working with Donna and other colleagues to release people to work in this different way. And I think we do have to acknowledge that we weren't starting from scratch here. There were some really good examples of integrated working, but it was quite piecemeal. So we have created an environment and given professionals the permission to work in a more integrated way. Pop the next slide up, thank you. So the ICAP core team is made up of professionals across physical health, mental health, and adult social care. And these are the core team, but they also reach out to wider teams, the wider MDT, and from that first model, lots of services, we're able to reach out to those wider teams. The criteria for ICAP is any individual who requires 2 or more of those services. So we've made a number of pledges around the ICAP, which I'll, I'll read out. So we'll make sure that right from the start of your journey, your individual needs are assessed jointly by an integrated team, and that is standard in ICAP. All assessments are done jointly across the team. We will make services easy to access, and no door is the wrong door. Very much a work in progress, but very much a core principle of what we're trying to do here. We will provide personalised care that meets your needs, that is well coordinated with all our community services. So to put this another way, let us navigate that complex system for you. Let us pull together the various elements and provide that care, wrap that care around the individual. And in doing all of this, we will avoid you having to tell your story more than once. Okay. So the wider MDT meetings, we obviously can't operate in a bubble in ICAP. It's effectively a service, it's an integrated service, but we need to ensure that what we're doing is communicated in the right way to the wider MDTs. Our example in the South neighbourhood is we are linking directly into an established frailty meeting where we have GPs, we have the geriatricians, we have a wider MDT, and that's our weekly touch base with the wider team to exchange information about the packages of care that we're putting in place for people referred to ICAP, and also to pick up referrals in that meeting. And then I've mentioned proactive care here. So I think our priority has been to get a strong operational model where we are working in partnership across multiple organisations. That's been our priority. And the next priority that Donna will talk about is rolling out into the other neighbourhoods. But we absolutely mustn't lose sight that we've got an opportunity to do more proactive work. So, for example, we can access the North West London WSIC dashboard. We know that lots of practice levels, lots of practices have a frailty list. We want to be able to work with partners, around that list and look at how we could intervene earlier with these people on those lists in order to prevent things becoming more complicated. And then another element of the proactive care is around strengthening the relationship from ICAP with voluntary and community sector. So we think those VCS frontline workers could really be our eyes and ears into ICAP and be our early warning system and let us know if they're concerned about a resident, feed it into ICAP, which might trigger a welfare check. So the model, starting with the infographic on the left, we are an integrated team, no door, no wrong door, joint assessments as standard. The proactive case finding I've mentioned is an ambition for us, and personalised care always. All assessments are done jointly with the individuals, an agreed set of goals. So the structure, the ICAP team is one team. And as we roll out, we will continue to be one team. So it's a borough-wide team that will take referrals, have the conversation and the allocation of the case to the core team. But in terms of how it's delivered, and how it's communicated back to the wider MDT. We are focusing on doing that at a neighbourhood level or an INT level. In the south, it's currently at a neighbourhood level. And our core team there's a list of the various organisations who are involved and the different professionals therein. So I think the only thing I've not mentioned here is in terms of the person-centred plan, we have adopted the Universal Care Plan as standard within ICAP. We know that that's really important, particularly if a patient or a resident needs urgent care or London ambulance, we've got a record and they can see what's been happening. And we want to try and be the trailblazer for using that and get other wider teams to use it. So what we found so far is we definitely have a faster response. So compared to pre-ICAP, when referrals would need to refer to multiple teams, we take those referrals, we meet every day in a daily huddle, and we triage within 24 hours. So our response is much more rapid. We've definitely streamlined the pathway. So again, that quite messy diagram. Between the core professionals, we've been able to name and list out the various pathways and the various teams. We now know people by name who to contact in order to bring the wider, often more specialist team in. Communication definitely improved, certainly between the professionals, but across organisations. And the last point, thank you. Oh, thank you. Yes, more personalised support. So, yeah, all assessments are done jointly with the patient or the resident and or their carer, and the goals are agreed with the individual. So I'm going to hand over to Donna, who's going to talk about case study.
Okay. Thank you. My name is Donna Barry. I'm the Assistant Director of Adult Social Care and Neighbourhoods in Hammersmith and Fulham. Good evening. So just to follow on from Ian's background to the model, I wanted to bring it down to the case study and what it's been like in practice for all the practitioners. So we wanted to share this case study as a really good example of integrated working. And as you can see, the background to this gentleman, Mr. X, who was actually one of the very first residents that we worked with in ICAP, had very, very complex medical conditions. He was living at home. He is living at home with his wife, who's also experiencing advanced dementia, and their son is their main carer. They had their own living care package, and they had support around making decisions from lasting power of attorneys and appointees. So they were quite well supported from that perspective. But as you can see, his medical condition was very, very complex and deteriorating, and his care needs were increasing. And whilst he was linked into particular medical practitioners for support, the aim of the referral to ICAP was to bring that all together into a cohesive, comprehensive assessment. It was triggered also by the fact that he was fainting and falling, and so it became critical for him to have that OT input. So the referral to ICAP was specifically around supporting him with his safety around occupational therapy, to ensure that there was joint working between the district nursing services and adult social care and the social workers, and also to make sure there was just a comprehensive assessment that pulled all those services together. Next slide, please. So the seamless interdisciplinary response started with the referral to ICAP, when it was clearly identified that he had particularly complex care needs. And very quickly, the community matron and the social worker went out to see him and his family to plan the next steps. And because the needs were primarily around his deteriorating health and his increasing care needs, the community matron provided that leadership. And she led with a holistic palliative needs assessment, identifying that end-of-life, his end-of-life priorities. And she brought in some of those services that were already supporting him. So the neuro rehab, speech and language therapist, dementia services, and the complex OT then came in from adult social care to support. And the community matron conducted a comprehensive geriatric assessment and completed a universal care plan and made sure that was shared with everyone across the services. The occupational therapy intervention was absolutely critical, and that's provided support around his safe mobility with the provision of equipment, and also reduced carer strain, both carer in terms of the son and the support he was providing, but also the privately arranged care that they had in place. And the OT case manager worked in very closely with the other professions to review the ongoing risks around some of those functional needs. The district nurses provided the pressure care and also reported to the community matron on the palliative day-to-day support they were providing. And the adult social care support was provided through the social worker, who provided that overview of home support systems, and we also provided a package of care. But the social worker recognised that Mr. X's care needs were actually tipping into the specialist needs around a health-led care provision. And so that prompted the referral to the continuing healthcare team, and the community matron followed that through and ensured that that fast-track application was made so that Mr. X was able to get the right support and the right skilled level of care to meet his needs. And the role of the ICAP was to ensure that we reviewed that on a daily basis, and all of those moving parts, all of those assessments, all of the outcomes were then very closely monitored through that daily meeting. And what ICAP does is it brings together all of those services in a really intensive, integrated way for a period of time that meets the needs of the residents, completes the assessments, and then we step down individual disciplines when their role is complete, and agree between the disciplines who will then be the most appropriate to hold that the management, the long-term management of that residence package and support. And in this case, it was the community matron that continued to support this resident, ensuring that continuity and ongoing monitoring in the community. Next slide, please. So just to recap, the conclusion was that we had the key disciplines working with very clear roles assigned to each of those disciplines. And together, through that integrated assessment, we ensured that there was daily team communication, that the team delivered a safe and dignified and person-centred palliative pathway that enabled Mr. X to remain at home in accordance with his care plan and his best interest, but most importantly, with his wishes. Next slide, please. And so the crucial next steps, really. So the patient or resident and staff feedback is absolutely critical to the development of the next step for ICAP. So we've had 41 care plans that have been completed by the core team. And with every intervention, we ensure that patient feedback forms are issued when we're coming to that point of discharging residents from the ICAP. And the really positive feedback so far has been that people have felt listened to, and they felt that their goals or the treatment plan has been jointly agreed with them and the professionals involved. People feel supported to regain independence as a result of ICAP, and they feel that they're treated with dignity and respect, which is absolutely crucial. From a staff feedback perspective, we held a workshop in October and brought all the staff together. It was really a chance to sort of stop and reflect, consider some of the successes, consider some of the challenges and some of the barriers, and also to look at what do we need, what do they feel they need moving forward in order to develop the model. And the feedback from the staff was really, really positive. People feel that they're very excited to be part of a creative and innovative new model of care delivery. And I think that's really highlighted in the relationships that they've been able to build across disciplines, across professionals and across organisations. So they feel really excited. They feel as though they are part of a new team, which was really, really positive. So there is lots of opportunities for joint working have been identified, and will continue to build. They will continue to build understanding and team cohesion. And the next steps are that we are planning to roll it out across the whole borough. So we're very excited about that. And while it is, next slide, yes, thank you. And while it is early days in terms of ICAP, And we know there is more to do. And we know as part of that, we'll want to continue to, with the data that we can evaluate the benefits and really start to describe the impact that ICAP is having. And I think we'll be able to do that once we have more data and we've rolled that out across the borough. But what we can say really clearly is that everybody that's been accepted so far onto ICAP has been contacted within 24 hours of being discussed at the daily meeting. Everybody that was seen through ICAP had a comprehensive assessment of their needs and goals jointly agreed with them. And I think, as Ian alluded to earlier, we've seen huge improved communication between professionals and organisations, which as we've seen reduced duplication amongst professionals. We've taken a much more sort of trusted assessor assessment process rather than duplication. So assessments are now shared. And all of that means that there's a reduction in time taken to engage teams outside of the ICAP. And in totality, that means if we're working more smartly and we're working together and much more creatively, that we will all have more time to see more residents, which is ultimately what we want to achieve. So the next steps for us will be to prepare to roll out across the borough. And we're all very committed to that, and we've committed resources from our existing teams to be able to do that. But we do understand that we'll have to monitor the demand and the capacity closely as we roll that out. We'll continue the development of the evaluation and outcome measures because we'd like to see how ICAP impacts on things like hospital admissions and keeping people at home in the community for longer. And as part of that, we'll be planning further ICAP team workshops and joint training. Thank you.
Brilliant. Thank you so much, Caroline, Ian, and Dana, for this update on the partnership. It's great to see how the new model of care is working, and also understand how the core principles shape this process as well, and some of the findings that you've identified as well as part of this process and plans ahead. So I'll move to the members of the committee. Do we have any questions? Jim, and then Councillor Bonner.
Thank you very much for that presentation. I think I was wondering what's the kind of threshold? Who can refer people to the scheme? Because it seems to me that anything that can streamline services for people, you are going to be inundated with referrals and with people that want to access your services. So what are your kind of thresholds? Who can refer? Is it just health professionals or?
Okay, so at the moment, it's only health professionals. By default, to date, it has been almost exclusively GPs, but we would want to open up to other health professionals. Our criteria is requiring two or more of the disciplines, if you like. So social care, physical health care, and mental health care. That's our only criteria at the moment. We do have to, it's adults as well. So anybody over 18. What we have found, though, the majority of the referrals, probably over 90%, have been for people over the age of 65, just naturally fell that way. Donna mentioned that we are monitoring closely our demand and capacity. We feel, based on the experience that we've had in the South neighbourhood, that with the resource that we've got, we should be okay. We've got good data on the types of people that we've been seeing in the South, the numbers of those populations and those cohorts in the centre and in the North. But we're reviewing constantly, we're in constant communication. It is a concern that we will become overwhelmed, and sometimes you can become a bit cynical of your own success, and the more the word gets out there, the more people will want it because of the response and the outcomes that we're getting. So yeah, we feel we're just about balancing the demand and capacity at the moment.
Thank you. I wish you every success.
Thanks. I was following up the question there. That was actually quite a fascinating presentation. I'm curious because, quite unlike the other presentations tonight, this is entirely professional focused. All of the other groups tonight are very much co-production focused, and that seems to me to be their strength. And by coincidence, right now, I'm an older person, only too obviously, from the south of the borough. I'm pretty active in my PPG, patient participation group, the chairs of which are meeting this evening. And as far as I could work out, none of them know anything about this. Now, I say this not to be satirical, but it's factual. When I read it last week, you've got a terrific graph. It's like a work of art, etc. on page 16, color-coded. But it's unmissable. It's reactive for the patient. Somebody else is in charge. You refer him or her to somebody else. But I actually don't see a feed-in mechanism, unlike any of the other groups tonight, where design can actually be carried through by patients. And given that one of the things which this borough is rightly, in my view, very proud of, is co-production, it's singularly lacking. So if I were to talk to somebody who said primary care, people know what they're talking about, secondary care, hospitals, they know about mental health services, I'll bet of the 180,000 people plus in the borough, that beyond professionals, if 50 people knew about it, I really would be astonished. And much of it seems good, but it seems to be at a distance from patient control, and we're the objects of somebody else's decision. And I know permission is asked all the way, but it's not a successful model. It's not been for the NHS. What's been successful is when people are pulled in at the start, help design it, and they improve things or say something doesn't work or something could be added. But the way it's designed here in these quite comprehensive slides, they're fascinating, is they're almost patient-proof. And I say that as somebody who would like things to be integrated as much as possible. I'm older, I'm a patient, etc., as well as a resident, but I can't see how I would have an in here.
Yeah. Thank you, Jim. I think there's probably a couple of things in there. So firstly, we've got an awful lot of both local and national evidence around people saying that they repeat their story too many times, that services are not joined up around the resident and their needs. And that's what we're trying to respond to and build here. And there's only so many ways in which we can respond to that and make sure services are joined up. I think for this cohort of people, the co-production is in the actual development of the plan, which is a very person-centred plan and is very much about the person and their carer and their families' actual goals and the kinds of situations and needs that the service is currently responding to are really very complex. I think the other key thing for us to explain is that prototyping approach. So what the team have been doing is trying something and building it and working with the people that they're actually working with to build that and get their feedback on what's working and not working. So that's where that co-production has been within the actual prototype of that individual model. Is there anything you want to add, Donna? Yeah.
In relation to this question, I would like to follow up. So maybe you can give us some examples, and I understand as well that how you're piloting the more or less, but I want to know if you could give us some examples where residents or patients have given feedback directly to shape the decisions or pathways. I think that would be also very helpful. Thank you.
Sure. So built into the model we have for every patient or resident, we give an opportunity for feedback. So we do have a set of questions, things that that are helpful for us in the design of the service, plus everybody has an opportunity to just sort of free text or give their views on how things were delivered and how they might want to see things differently. So again, it's relatively small numbers at the moment. We will keep getting that feedback through the people that we're treating and their relatives and partners, etc. So far, the feedback has been really, really positive. I think we do want very honest feedback, and I think sometimes you have to look at how you get it. If it's with the clinician that you've been working with, are you more likely to give positive feedback? So it's something that we're thinking about in the model, but we are proactively getting that feedback.
Sorry, Jim.
Could I come back to that?
Okay.
Because I live in that area. The PPGs really are active. We're very positive about improving things. We're all in favor of integration, but it's the feedback is not the feed in at the start. Remember, in the large survey, which cost an awful lot of money, carried out by the ICB, our PCN had one of the highest report backs in Northwest London. It really was way ahead of most others. And not knowing about this until I read it, it actually surprised me. So ringing around the other chairs, they also were surprised. And I think you would have a much stronger understanding and a much more constructive way of getting into prevention if this were to go back soon to practices, to PPGs, and people were given a genuine chance to offer their take, what can be improved, because without that, you will actually be processing people in a better, more streamlined way, but it's processing. And that's what I think the NHS is trying to get away from, because it didn't work.
From the feedback that we're getting from Jim, I wonder whether for the new plans that you have in terms of the other neighborhoods that you're going to be rolling this out, can this be incorporated in terms of the model? Or the communication aspect of it, Catherine?
Thank you. Yeah, I was just going to say probably what Caroline possibly was going to say. GPs are very aware of this service because they're the people that have been referring in. And you've mentioned yourself, there are groups that are part of practices where those things can be shared with people who are registered with the practice, and people can feed back into their GP about their experiences. I think I understand where you're coming from, but I think we just have to have a starting point somewhere. And as Caroline said, there's lots of evidence nationally that people have said repeatedly they don't want to have to keep repeating their story. They want to have a single point of access. They want to be able to have their care and support streamlined. And this is specifically for people who have complex needs. It's not for the entire sort of population. So I do understand what you're saying, but I think actually the team have done quite a lot of work to ensure that this is as widely shared as it can be, given that it's working in one part of the borough. And that feedback that they get from individuals who have received a service from them, I know that they do take that on board. They are collating that and they are looking at, actually, does this mean we need to do something differently? If so, what is that? And how do we get to understand that better?
Thank you very much, Catherine, for that. Okay, I'm going to have Lydia, please. And afterwards, I'm going to invite Victoria.
Thank you. Like others have said, always, I think, really good to see more integrated services, and particularly thinking about the fact that you said that the referrals have so far either mostly or all come from GPs. I'm just mindful of the national government's 10-year health plan and its impact on general practice, and this move towards neighbourhood health service and neighbourhood health centres, I think they're called, where instead of being just based in surgeries, GPs could be covering areas of at least 50,000 patients, if not more. Given that this system seems to rely on GPs knowing their patients well and having that continuity of care, is there a risk that actually what seems like a really good scheme could be not undermined, but perhaps not made best use of if we do see this shift in the neighbourhood health centres and if GPs are suddenly sort of covering much larger areas? I'm not asking you to comment on sort of how good government policy is, but more about how if GPs have raised the risk, or if there is a risk there in your eyes at all.
I think it's a really interesting question, Councillor. I suppose our GPs are already working in sort of neighbourhood footprints, and they're quite large neighbourhood footprints because in a complex urban geography and our map of practices within the borough, it's quite difficult to make it to make it much smaller. But that doesn't mean that undermines the individual relationship that a GP has with their own patient. So we know that our practices operate differently. One of the things that I've been really keen to make sure happens is that we flex, and that the team and the model flex to enable the input of different GPs, a wide range of GPs, so that the patient's own GP is the one that the discussion is with, and it's not just somebody operating on their behalf. Because having that flexibility to be able is really key, because we know that that's what patients want. They want that continuity of care in the relationship with the single GP. I think what I can't say at the moment is what is going to happen with new contracts as they come down the line around neighbourhood health, but that's something that we've been really clear about building into the model locally, even though it doesn't always make life easy, that our 28 GP practices working in 5 different primary care networks do all work in some quite very different ways. But I think we are confident that we are responding to that currently, aren't we, team? Yeah, we are.
We are. And sorry, just to add to that, as an additional safeguard, I think the work that we will be doing around proactive case finding sort of takes out that reliance on, because we know that some practices in our experience are bigger referrers than others. And I think that by having that proactive element, identifying the cohort kind of equalizes it across all referrers and all GPs. So I think that's an additional thing that will help.
Thank you very much. We now have Victoria.
Hi there, can you hear me okay?
Please
Can you
go
hear me
on.
okay? Yeah. The comment I'm about to make applies not just to what you've been talking about, but also perhaps wider as well. Thank you for your presentation. I'm very much aware that the quality of service users support depends not just on getting the structures right, but also on the quality of the individual professionals they come into contact with. I recently had dealings with 2 health and social care professionals in this borough. One was absolutely brilliant. He was compassionate. He understood my needs. He treated me with respect and dignity. The other person, I have to say, was absolutely dreadful. She was arrogant and harsh, made no attempt to understand my needs, didn't listen to me. Thankfully, I'm mentally strong, but if I wasn't, then some of her comments could have been quite psychologically damaging. And it has made me realise that there is still a lot of variation in the quality of professionals. Now, I think we ought to kind of try and explore solutions to this. I'm aware that hospitals now have Martha's Law, so that if you've got concerns about the first team who are treating you, you've got a right now to ask for a second opinion with the second team. And I wonder if there's some scope for having a similar scheme in the community, so that if you come across a professional who feels not doing their job properly, you can ask for essentially a second opinion and be put in touch with somebody else who can deal with you. I'm just throwing this out into the meeting just to so we can sort of contemplate what we can do about this. So yeah, that's just my thought for this evening.
Thank you very much, Victoria. Like to respond?
Yeah, so I can't comment on the Martha's Law for the community because I'm not aware that there's anything in the pipeline. But what we do know from patient and resident feedback in the past has been with this, that complex picture that I presented earlier, multiple providers. Therefore, there are multiple complaints processes, and people were unsure, to complain to CLCH or to the local authority, etc. I think with ICAP, because it's an integrated team, if somebody's unhappy, they send one message to the ICAP and we will go to the respective organisations and we will investigate that and look into it. So I think it goes some way to addressing what's been raised, but yeah, that's it.
Okay, thank you so much. If there are no further questions or comments, yes, Fiona.
Just an offer of support, really, more than anything. When you're looking at the proactive work to look at case finding, I'd be really keen to share some of the learning from our safeguarding adult reviews, particularly around kind of communities that are harder to reach, a term I really hate because it's more about our inability to than it is theirs. But yes, that I'd be really keen to talk to you about how we might help shape that, taking on board your comments too.
Thank you, Fiona, for that offer. Well, thank you so much, Caroline and Donna, for your presentation this evening. I've heard a very positive update in terms of the partnership and the integrated model. The references that you've made in terms of the seamless aspect of the new model, those comprehensive assessments, the fast track element, the 24-hour response, getting back quickly to residents with complex needs. I think that that's very positive and that's welcome. We also heard some interesting feedback and suggestions for this evening that perhaps we want to think about for the next stage. I wish you all the best with the new phase that's starting, and yes, hopefully we'll see you soon for an update next year. Thank you very much. Great. Okay, let's now move on to the next agenda item, which is agenda item number 5. We've got Hammersmith and Fulham Safeguarding Adults Board Annual Report 2024-2025. And with us this evening is Fiona. Welcome, Fiona.
Thank you very much, Chair. And I'll kind of assume that everybody's read the report, and I will just start by thanking Kerry Gordon, our SAB board manager, for her excellent report. I'm here as a figurehead. The vast majority of the work is done by a lot of other people, is all I'll say, some of whom are at the table. So the report just really gives a highlight of the activity over 24-25. Feels like a long time ago, but there has been a lot of work over that period. So it was the second year of our strategic plan, my first year as independent chair, and I, yeah, I mean, as I said in the report, was really welcomed into the board. Was, you know, I've found the strength of the partnership something that was really very well established, and quite a joy to behold, to be honest. It's not always there, so it was quite a nice thing to find. In terms of the report, there's, as you'll see, we've detailed kind of the main statutory responsibilities that a SAB would normally have, and primarily that's looking at, I mean, the strategic guidance says that we have to do 3 things. 1 is have a strategic plan. 2 is produce an annual report every year and come to boards like this to showcase them. And then we have to undertake safeguarding adult reviews, which is why it's been given such a focus. Historically, Hammersmith and Fulham hadn't done very many reviews. They published Alison and Brian the year beforehand. And you will have seen from the report that actually, as is often the case when people realise the value of a safeguarding adult review, they think actually this case also should be looked at in that way. And so we have seen an increase in our referrals. I don't think that's anything to worry about. I think that's the sign of a healthy, open culture that wants to look and learn from the deep dive that those safeguarding adult reviews provide. So the Hussein case that we completed over that period really focused on sort of transitions and supporting individuals, particularly where there's cultural knowledge gaps, and how we work with families from different backgrounds, individuals of different backgrounds. For me, the strongest thing that came out of that review was thinking about how we empower adults to make decisions for themselves, with support of friends and family, of course, but fundamentally hearing the voice of the adult at the centre of it. And I think we found that difficult in the Hussein SAR. So that's something that we're still working on and something that we still want to kind of really think about. But it also talks to the ICAP work as well, that, you know, around integrating and navigating systems that are really sometimes very complex. Adult D looked at mental capacity and sometimes the presumptions that go along through that. We've got a really useful thematic suicide prevention piece of work that Public Health have funded, that is ongoing at the moment and will shortly report. But it's looking at why the suicide rate in Hammersmith and Fulham is slightly higher than London and the national average. to think about what we need to do here differently. So that's particularly focused. And adult E and F are looking at domestic abuse. 2 different cases, which thankfully didn't result in deaths, but so it didn't meet the statutory criteria for a homicide review, but did result in serious harm to adults with care and support needs. So thinking about how we pick up on, you know, the difference between domestic abuse and carer strain, because sometimes these are nuanced, but they are really critical that actually our providers and our staff are comfortable, confident, our neighbours are comfortable and confident to report that in. The other one that is mentioned there is a review again funded by Public Health, looking at chemsex and the kind of work that's needed to kind of support very vulnerable communities and individuals. And then adult I, which is where I really wanted to kind of connect with the ICAP work that's going forward, because that one will be looking and focusing on how we work with individuals who've experienced multiple disadvantage, often for very many years, sleep, you know, in our rough sleeper populations, but also in our homelessness population, and think about how we move them from the specialist homelessness health pathways into mainstream. Because I think if we can get it right for that cohort, we can get it right for our whole population. So those are the reviews that we're getting a really wide breadth. You know, these are areas where I kind of went out to other chairs nationally and regionally and said, has anybody known of anybody done reviews like this before? Because what should we be really looking at? And everyone was like, no, you do it first. We'll all learn from you. So it's a really positive approach, I think. And as it sets out there, the how we taken forward the strategic aims. So our 3 things were effective systems, creating a culture of learning, and creating that strength in that partnership working. And I've just kind of, Kerry and others have set out the kind of work and who's doing that, and what we feel that we're achieving in that kind of, you know, that partnership work together. So yeah, I'll be back here this time next year to talk about what we've achieved in this year as well, which is more of the same. But I don't know if anybody's got any questions.
Thank you very much, Fiona, for the update on this year's work. Yes, please, Jimmy, go ahead, sorry.
I've got one comment. This really is an excellent report. It's got the feel of time, and the staff are obviously remarkably hardworking and resilient, and I think you're to be congratulated on that. I would like to focus there on one thing. It's on page 33, responding to abuse of staff. And I think that for a very particular reason, at the most recent acute board in Common, the chair, Matthew Swindle, right at the start, said he wanted to make a statement on behalf of all of the acute providers. They're facing an astonishing increase of racial abuse to staff. And he said, this is the kind of thing they've not been coming across before. And coincidentally, the Royal College of Nurses got out a very detailed report on racial abuse of nursing staff as well. And that was followed, I know, in some of the local GP practices by saying that some staff, quote, from abroad, I'm from abroad, by the way, were actually getting the kind of comments recently, which they've not had before, about their origin. And I think this is to be utterly deplored. And it seems to me that we need to work with the other providers, the acute providers, to work out a strategy to support staff.
Yes.
Because staff should not have to face abuse of any kind. But the increase of racial abuse is something new and is much more structured as against the old person in the past. And it does seem to me that at the council, working with the acute sector, with your grouping and others, I've got to say that giving a service to patients doesn't mean that a staff member is a punch bowl, and particularly not for racial abuse, that patients don't have a right to do that, and staff have got a right to say no. So I think we should have a strong statement of that kind.
I couldn't agree. Fine. No, I absolutely agree. And I think there's one of the things that's really interesting, to be fair, it's work that I've done elsewhere, but would apply directly to this, is we see a very significant rise in hate crime as a consequence of international issues. So the charity Hope Not Hate, I think, has done a lot of work on what's happening in other parts of the world and the impact that has on our local communities. So learning from that and applying that. In actual fact, in the Brian case, the focus for the SAR in the Brian case was thinking about how you support practitioners who are facing abuse, stay open and still able to respond positively. But there is a balance always to also working in an environment that's safe for you as an employee. So there is, I think, a lot of work that as a safeguarding board we can be doing to think about what does that mean in the context. And actually that's one area where I think we really need to reach out to our community groups and to our VCFS colleagues to really think about how do we do that and what should that look like. Because it should be very clear to anybody that, you know, actual racial abuse, any kind of, you know, abuse against our staff wouldn't be tolerated and shouldn't be tolerated. But yeah.
Thank you very much. I totally agree with both of you. Absolutely, and would very happily support such initiative. Definitely, I mean, it shouldn't be tolerated at all.
I wonder, could we have a report on what you've done when you come back next year to strengthen the resilience of staff, the protection of staff, and to how you develop a culture where patients and residents know that certain kind of behaviours will just not be tolerated. The council doesn't tolerate things, quite rightly. And I think health professionals who look after people's health and lives shouldn't have to put up with the kind of abuse which has suddenly begun to mushroom.
Thank you very much, Jim.
I'll do my best.
Thank you for that suggestion and thank you for raising this. Councillor Sanderson?
Thank you. Just to say, obviously, we absolutely deplore any form of racism or abuse that anyone would face at work and would want to do everything to send messages of support to that staff. I think I'm just worried about there being the pressure on the safeguarding chair to try and deliver that when it's obviously not your role. But we would encourage workforces to make sure they have got adequate support in place for staff. And I'm sure that can come up in safeguarding, but obviously it would be quite hard for you to go into every single workplace and make sure they have got that there. But thank you.
Thinking about actually that kind of wider support and reaching out to staff that are working with people who are sometimes going through very, very significant challenges themselves and what that balance might look like. So there's a lot of guidance already available on the SAB website, for example, around responding and keeping yourself safe and doing that self-care in the context of safeguarding work, which sometimes can be incredibly impactful for staff, as well as, you know, they know that they're there to support and care for and keep you know, our residents safe, but actually some of the work they do can also have an impact on their own health and well-being. So it's those kinds of areas where we might have an aspect have an extra little bit of you know, some work to be done.
Thank you very much, Fina. Yes, and I agree with you, Councillor Sanderson. We've got Victoria. Victoria, would you like to go ahead, please?
Yeah, just a quick comment. I just wanted to add my support to the comments that Jim and Alex and other people have made. Racism is totally unacceptable and should be completely deplored. I wonder whether it's worth next year, when the council is planning the Unity Day, whether there could be a particular focus on celebrating the work of staff from all backgrounds and the contribution they make to the health and social care system in the borough. Just a thought.
Thank you, Victoria. I think that's a very positive suggestion, and yes, I'm happy to explore that as a follow-up action. Definitely, thank you. Are there other question? I've got a question, Fiona, please. So what themes have come up regarding interagency communication, information sharing, or professional curiosity, and how are these being addressed amongst the different
things?
Right.
So within the safeguarding adult reviews that we've done, they are deep dives into particular cases, but you then look at how do these cases shine a light, if you like, on the wider systems. So often there might be issues around, you know, are people being, you know, have we talked about ICAP, are they being proactive, trying to find individuals, you know, are they identifying types of abuse in the right way? So for example, with the domestic abuse review that we're doing, we're looking at, did people respond to that in the context of care restraint, or was it recognised that this actually could be an abusive situation? What could have been proactively put in place to support the workers to ensure that actually those individuals were safeguarded? And you know, the information, what ICAP is suggesting is kind of like the gold standard, but it's what we'd like for everybody. Of course it is. Our systems to navigate them can be incredibly complex. Our GPs, as we've already heard, will be going to much wider footprints, and that might pose its own challenges. Resources are tight across all of us. So there's areas where we're looking to influence and help shape change through the safeguarding reviews, through the data that we're seeing, through the good practice that we also see. So yes, you know, the national SAR analysis, the stuff that we're finding locally is that there are sometimes problems with information sharing, but there's also some really good practice. There's some issues around people genuinely properly understanding how you apply mental capacity, how you balance that right to autonomy with the right to stay safe, because that's different for every case. And I think practitioners sometimes can find that really challenging, particularly if you've only got 6 minutes to see somebody. But it's helping people unpick that. It's helping people navigate the systems, or like you say, utilising the complaints process or utilising the escalation pathways that we've got to kind of make sure that the right decisions are made as soon as they possibly can be. And that's kind of, yeah, that's kind of the role of the board, is to really kind of try and help shape that good practice, so it's not just a small initiative in one part of the borough, but it actually becomes business as usual across all the services.
Great, thank you very much. Yes, I like what you said at the beginning, the fact that we may have a few more referrals. Just it's an indicator that's it. It's a healthy indicator basically, which is positive.
Yeah, I mean, I'd like to get to a point where we're not so busy.
Yes.
I'm not going to tell a lie, but it's sometimes when people see safeguarding inquiries going up, you think, oh God, that's bad. That means people are less safe. But it's that people are recognising that an adult might be at risk of abuse and they're asking for help.
Yeah.
And that's really good. Yeah. So if you see a little bit of a rise, it's understanding why that's happened and then being confident and comfortable that we're responding to it well. And I, as the independent chair, feel that certainly the partnership is committed to understanding the data and the information that we have, growing that and being able to deep dive into kind of the initiatives. They're open to me coming to meetings and saying, could we think about doing it this way, which is positive.
Thank you very much. Other further questions, comments? Councillor Sanderson.
Thank you, Chair. Just to say, much like the last one, I think this is actually a really positive paper. As you say, when you first see the numbers go up, it can be a bit alarming, but actually it's because people have more faith in the system, so it's wonderful. And on top of that, introducing SAR policy, introducing escalation pathways, strengthening the Safeguarding Adults Case Review Group, refreshing high-risk panel terms of reference. There's been lots and lots of really positive work in there, so thank you for all of that. As you move into this year, looking at testing impact more than activity, can you just talk us through how that might look? Thank you.
So what we introduced last year, and a couple of things. Firstly, one of the things that we're looking at with some of these reviews, these safeguarding adult reviews, is it's not just can you tell us what went wrong, it's have you seen any improvements from the situation. So the terms of reference have been framed around where are the improvements, where are the gaps still, but picking up on where there is that persistent. We've undertaken audits to look at self-neglect, to think about actually how, is that improving? Is that practice from the reviews that we picked up on, is that kind of starting to shape practice? We are looking as well at the data in much more granular detail and starting to see pictures emerging and supporting the fact that actually people are more comfortable and confident talking about safeguarding and talking about abuse and picking up in on different aspects of it. As I say, I think we've been very brave to kind of open some boxes that maybe in the past or in different areas, they'd be sort of like, well, I'm not sure if this is adult safeguarding as such, this is more, but actually working with our partners to be really thinking about it from a public health kind of, you know, whole residents kind of perspective is really helpful. It means we're not going to always be reactive. We will be thinking about what might be coming in the future as well. So we are, I think, in quite a strong place because from January onwards, we're going to need to be thinking about the next strategic plan and where we want to be going to and what we want to be really focused on. There's a lot of change across our statutory partners. That means a lot of change in the personnel for our board. And so it gives us an opportunity to also think about actually where do we want that focus, and in order that we have, you know, as with individual clients and individual residents, that continuity of care for them is really crucial. For us as a partnership, continuity across one strategic plan to another is going to be really important. So you're building on and you're not distracted by something new that's come in. Does that make sense? So it's trying to build gradually. It's trying to keep up the momentum and keep up the profile of safeguarding adults, and ensure that actually when there is change in personnel, when there is change in priorities, that focus remains and we're building on year that kind of progress, as opposed to kind of, you know, just losing sight of actually this is our bread and butter and this is where we need to start and get it right in the first instance. Hope that helps.
Thank you very much, Fiona, for coming here this evening as the independent chair of the Safeguarding Adult Board. It's great to hear the work of the board in the last year. We also, we note and the report and how you've met the objectives of the board, how you're progressing in your strategic objectives as well, and have improving safeguarding across the board, which I think it's very important.
I will just be very clear, it's not just me. There are thousands of people that are doing this. But yeah, I will share your thanks and your views with the board.
You've alluded to that culture of learning, which is so important, isn't it? And that strength in partnership, which is really good. Excellent. Thank you very much, Fiona. Okay, let's move on to the next agenda item. Agenda item number 6, Charing Cross Hospital co-production with Action on Disability. It's great to see you here, and some have got Jack, Jenny, and Matt. I'll ask you to introduce yourselves in a minute. It's about a year ago, we had an update here in the Health and Adult Social Care Policy Accountability Committee of a work that was carried out by Action on Disability. So Victoria, who's joining us online, suggested that a report is produced, led by Action on Disability, focusing on disabled people's experiences of the NHS. And they came to committee, and we heard some of the challenges that were identified. So it's good to see they're back a year later with Charing Cross Hospital as well. So welcome, and yes, please go ahead and introduce yourself. Thank you.
Thank you, Chair. My name is Matt Ayres. I'm the Hospital Director at Charing Cross. I'll let Jenny and Jack introduce themselves.
Hi, I'm Jenny. I am a service user of Action on Disability. I'm also a resident of Hammersmith, Fulham, and I'm a service user of Charing Cross Hospital.
Hi, my name is Jack Hill. I'm a trustee of Action on Disability. I'm an accessibility consultant, and I'm also a service user of Charing Cross Hospital.
So just, you've given some of the context there already, but what I'll do is just go through how we got here and then hand over to Jenny and Jack to go through the site visits that we did, and also the process we've been through over the last 7 months. Do a quick summary of some of the highlights of the progress, and then maybe reflections from Action on Disability and from the hospital, and then just open up to any questions that you might have. So I started my role at Charing Cross in August 2024, and one of the first things I did was try to get to know people else. I think
My mic's not on. There you go.
closer to me. And one of the first things I did was try to get to know people outside of the confines of the hospital a bit more, and part of that was getting to know people in the community, the borough, the providers, community providers, etc., primary care. And somebody fed back to me that there'd been this report at HASPAC, and they said, whilst Charing Cross wasn't mentioned at all, it came up quite a lot in the conversation that followed. So I got in touch with Nikos, who's here, who's the co-production lead at Action on Disability, to really take a look at, is there anything we can do in response? And we went from there. So I'll hand over to Jenny.
Well, I'm one of the original visitors who took part in the 2 visits that happened in Charing Cross. We visited the emergency department, Riverside ward, outpatients, diagnostics, and radiology as well. During those visits, we had 2 service users who were wheelchair bound. One who is manual wheelchaired and one was electric wheelchaired, and both of them have got complex needs themselves. Myself, who has got complex needs and use a walker and walking sticks. And I've also been recently diagnosed with autism and ADHD myself. So I do apologize if I waffle on, just tell me, be quiet, please. We had most of them were service users of Charing Cross Hospital as well. So the highlighted things that we noted that was poor signage and very hard to negotiate the hospital. We understand that the hospital is a very outdated building, and it's going to be very, very hard to put it correct or put things into place because of the structure of the building. Long waiting times and lack of quiet areas, physical barriers like in corners, corridors, toilets. We also found that pull cords were strung up as well, which shouldn't be strung up. So we addressed that with Matt. Matt was walking around with us, and we all took it in turns to actually sit down with Matt and explain what our barriers are and how we can actually help Matt understand what our barriers are. Each person is different, each disability is different. So we tailor-made it around what we can help with Matt. Jack, to my right-hand side, is a wheelchair user, but he is also deaf as well. So the barriers that we faced with residents and patients who are deaf is very, very hard to get an interpreter. So we also are trying to work in correspondence with Matt and understand things with that. So during the 2 visits, we actually helped with each other.
Sorry, Jenny, to interrupt. Can
Sorry.
we please move to the next slide?
Sorry, should I have prompted someone?
No problem, no problem. No, thank you.
So during the visits, we actually sat down and spoke about what the next stage is. How can we work together? How can residents and service users come together and work with Matt to identify what can be helped? So I will pass you on to Jack, who will be talking about our meetings. Next slide, yep.
I think the most important thing to talk about, sorry, I'm going to look at the screen over here because I'm reading the captions, is that disabled people were involved at every single level. This was actual co-production as opposed to a tick box exercise, which I feel like a lot of the time co-production can become, where the service comes to the service users and basically are asking us to sign off on work that they've already done to say it's okay. So I think everyone was very, very happy to have been involved at all levels. And whenever we brought anything to Matt, Matt then fed back to us on that and the conversation was continual. Where am I? Already spoke about. Lost. Sorry.
You're on this one first and then. we
Take your
can
time.
answer at Each meeting. That's the what we're doing. So we've got the actions and-
Yeah, I'm sorry, I've completely lost my page. The actions is that we had from our meetings were for the first one for Matt to create an action tracker. A big point that was mentioned multiple times was exploring volunteer support for disabled and neurodivergent patients. The general experience from the majority of people was that they had quite negative experiences with the volunteer staff. A lot of that comes down to systemic issues, with ableism being every single level of healthcare, and it's unfortunately just embedded. So that doesn't necessarily reflect badly on you, but just the system as a whole. We spoke earlier about wayfinding and signage, that a lot of visually impaired people and people with neurodivergence struggle to find where they're going in the hospital, and then also to find a toilet that they can actually access. Where was I? Yes, and we have very excitingly a new changing places toilet, which will be proposed in the redevelopment. I don't know if you know, but accessible toilets are often just not accessible, but changing places toilets are accessible for the vast majority of people. So that's a very exciting addition. Yeah. An agreement was made for monthly follow-up meetings and stronger co-production structure in the future. I don't know. Yeah, please.
During these meetings, we actually had very big updates from Matt all the way through. We've actually met the architectures as well, who's going to be doing the front part of the new build. And we've got a meeting with them tomorrow as well concerning the toilets, especially when it came to a couple of things that came up within the changing of the structure of the toilets, about where the doors are situated, especially for the new disabled type of toilets, and also the changing place as well. Because within that changing place, I take it, Matt, you should know more than I do about what's going to be inside the changing place. No, not yet. We haven't got to that yet.
That's the architects.
That's the architects. Sorry, I'm getting a bit ahead of myself. But at all the way through, we have worked together, and we've always come together. If one of us had an issue, we would go and speak to Matt, or we would go and speak to Nikos, and saying, like, we couldn't. I find it very hard sometimes to articulate my wordings, and I become very non-verbal sometimes. So when that happens, I can't talk on the actual day. So I tend to write it all down after I've done the meeting and send it over to Nikos to say, could you please pass it on to Matt? This is what I'm trying to get at. And sometimes it doesn't always go according to plan, but they've both helped within all of it as well. So that's how we've come together so far. I don't know if Matt would like to say anything else.
If I just talk briefly about the summary of some of the progress areas, you've got these in the pack already, some of the appendices, but I think it's been really exciting, partly because some of the things that we're doing at the hospital anyway has given us the opportunity to actually really influence the way we do things. And one of the things you'll see is we've surveyed all of the doors on the ground and the first floor. One of the things that really came out from the site visits was just how impossible it is to navigate the hospital, well, in a wheelchair, but frail elderly patients, etc. Because if the doors haven't got a magnetic lock or a push button to open them, they're heavy doors because they're fire doors. So we've got a commitment from the Director of Estates that we're replacing all of those in the next 18 months. The other thing, like we mentioned, we're redesigning the whole front entrance to the hospital. So as you walk in the doors, right the way through to the lifts is going to be completely different. And that has given us the opportunity to actually look at toilets properly. And we got the architects in from the initial scoping drawings. They came and had a long meeting with you. And like we said, they're coming back again tomorrow. I won't be there to go through looking at the designs again because there's further issues. The volunteers Jack mentioned, so the volunteers in December, we are starting a new scheme as a pilot, which will only be open to Action on Disability members or people connected to them to start as a pilot, where people will be able to request a volunteer to actually meet them at the front entrance of the hospital and then to almost accompany them through the hospital to be there to support them to get to the places, to navigate, etc. So that's going to be really quite exciting. The volunteers are really excited about how we can expand that out and have things like help points for people to press a button and then someone will come to support people. The other thing is wayfinding. We know that wayfinding is not good, or finding your way around the hospital is an easier way of saying it. It's not good for anybody, let alone people who've got the added difficulties of a disability or challenges might bring. One of the things we're looking at is working with external companies where we can actually use the new infrastructure we've got in the hospital to track medical equipment to actually give people almost a guided map on their phones to go around the hospital, which will have disabled friendly ways of working. It's too technical for me to answer any questions on that, but it looks very exciting from what I've seen. And the other thing is we've got the lead for autism and hidden disabilities coming into the group for the next meeting to talk about how we actually educate our staff better around dealing with people with disabilities, but also hidden disabilities. And that again is really important. We co-produce that, so we're not doing that to people. And then the final thing has been mentioned already, the deaf and BSL. We know we've got more work to do around that. And again, I think technology could help us. But that's sort of where we've got to. And I don't know, it's a summary from a AOD point of view.
Yeah.
The AOD Charing Cross Hospital collaboration has matured from initial access visits into an established co-production process, influencing both design and patient experience. Architectural designs from August to September reflect significant accessibility improvements, and ongoing work focuses on ensuring continuous involvement of disabled residents, sensory design, and sustained staff awareness. AOD remains a coordinating body for co-production with Imperial NHS, ensuring disabled people's lived experiences directly shape the hospital's future development.
Okay, and just finally, from my perspective, it's been fascinating to see the hospital through a new lens. Someone once said to me, the worst people to run a hospital are directors and doctors, because they never see the hospital in the way anyone else sees it, because either people are falling over themselves to help, or you know everybody, and therefore people will help you anyway. And it's really interesting this process to actually go through and look at it. So seeing things, the difficulties people face and the challenges that we've got around the estates and facilities, which is easy to say, there's nothing that can be done. But what we've actually discovered, there are things that can be done. And sort of, and separate, so that's the practical side, the estate side. I think The other thing which we've got a lot of work to do on is becoming much more person-centred. So we're looking at our patients from the lens of what do they want from us, rather than what are we going to do to them. And that's a huge challenge. And one of the things I've really discovered through doing this, it's been quite a challenge because my levels of ignorance have been immense around what people face, because I just don't know. And that's been a huge learning for me, which is ultimately positive, but it's being able to put yourself in that uncomfortable place where you just admit you don't actually know what the answers are, and trying to get the answers from other people. I think finally what I'd say is the staff, vast majority of staff really want to be helpful. They really want to feel that they're doing a good job and supporting people in the right way. And I think we just need to enable them to do that. And a big part of that is listening to what people do. Someone mentioned the call for help cords. I was on that tour.
Yes,
I know what happened is the cleaner tidied them away to make them look neat and tidy. And so that is a member of staff thinking they're doing a really good job, and what they've done is put the cord bells further up the wall, looking very neat and tidy, completely useless to anybody who's fallen on the floor. Anyway, that's enough from me. Please ask away.
Thank you so much, Matt, Jenny, Jack, and also Nicholas at the back. I know you've been leading this process as well, so thank you. And you were here last year, so it's great to see you here again, following up and sharing with members as well what's happened since the report was discussed here at HASPAC. I have Victoria, who is joining us remotely. Victoria, would you like to ask your question, please, or comment?
Yeah, it's more of a comment really. As you mentioned, I was the person who initiated the AOD report that has led to this process. And I'm really excited to see that the acorn I sowed has grown to this huge co-production oak tree. And I want to thank all the people involved. I want to thank Nikos, AOD, Matt at Charing Cross, and all the several people who've been involved in this co-production process. You've all done a fantastic job, and thank you for making a difference.
Thank you so much, Victoria. Definitely, you suggested that we look at the report in more detail, and it's great to see the report, the second part of the report here today, and learning what that partnership has done as well, and the findings, and how change is being embedded as well. That's really positive. Yes, Councillor Genevieve.
Hello, so I have two questions about, just to say that was a really good report. I'm really pleasantly surprised. Well done. It was so good. It's more, first of all, it's related to your question. I was going to ask you how you'll go about, or all three of you actually, educating staff, particularly well-meaning staff. I mean, I work in a clinic myself, and I can't tell you, it's not even just the cleaners. You meet nurses and doctors who tidy away the pull cords, and they're actually so proud of it. They're like, look what I've done. I've actually stopped a trip hazards. They're so proud about it. So how are you going to go about educating not just the cleaners, but the nurses, the doctors, the radiotherapists, everyone?
So from my perspective, that is about getting the people who've got the experience actually involved in the training, which is starting already. There's some all-day training now on things like autism, etc. But I think it's really about how do we get the people who do the training to be talking to people like yourselves about what is important. And I think it happens to a degree, but I think there's a lot to do. I don't know fully the answer, other than the best way to do it is to get people with the lived experience involved.
I would say with Matt's idea is starting from scratch, where you get people like ourselves who are disabled coming to the staff and saying, right, you're doing a brilliant job, but please, please, please pull cords are for this use, particular reasons why. I know you want to go and tidy them up. I know you want to do a trip hazard, and it's a trip hazard, but it's there for a particular reason. So if you start the training from when they come in, starting work with Charing Cross, start the training from the beginning. Unfortunately, we can't start the training from when they started becoming GPs, doctors, and things like that. That's the medical model side of things, not the social model of disability. If they start the social model of disability when they start becoming training doctors, then that might actually come across more better.
Please go ahead.
Okay, the second thing is I was pleased to see that there was also positive feedback. So I wanted you to delve more into the case about the radiotherapists and how you felt that their care was really person-centered. I want you to sort of elaborate on that because I thought it was really nice to see a positive comment like that, see what that actually looked like.
Well, it's when they actually spoke to us and they came out and said, well, we know for fact the changing rooms are very, very small. We can offer this type of changing room, which is another area completely, especially for those who are wheelchair bound. They will also were intrigued about my lanyard because I have the sunflower lanyard. So a lot of staff didn't understand what sunflower lanyard meant. And that's when they started asking questions. They asked questions about what type of things do they need to look out for. So I have an autism passport as well. I sometimes, because I can't articulate what I need on the day, I hand over the passport. Some of them didn't even know what an autism passport was. And that's something that needs to be brought in from the very, very beginning. And the NHS are very lagging with what type of needs from the start of what the patient needs. They don't look at, okay, then that's a patient and that is somebody that needs help. They look at, that's a patient, we must fix them. That's the way my brain works. I do apologize. But it feels like if you speak to us at the beginning and understand we are people, we have a disability, but please treat us like you want to be treated yourself. Treat us like you want to be, your mum and dad or friends and family want to be treated. Don't treat disabled people like they're nothing, basically. And that's how we've been working with them to actually understand. We've been getting Matt to look into some training as well on how we can actually help each other. So yeah.
Thank you very much. I have Councillor Sanderson first. Councillor. Okay.
So what my query was building on what Victoria said when she was talking about my report. You're meeting with the architects tomorrow. I bet they've got a lot of learning from working with you. And I wonder whether they might be minded, because knowing a few architects, they might be well up for kind of putting forward the work that they've done with you and what they've learned from you and the improvements they've made to Charing Cross Hospital into architectural, articles, into awards. And I think that would be a really good way of showcasing the impact that you guys have had, the three of you and others, around kind of really shaping what you do, what reasonable adjustments mean in the context, because it's bringing the law into life, isn't it? And so I think, yeah, tomorrow, if you're meeting with them, just see if they've not already given thought, whether they would give thought to kind of putting you guys and them up for some sort of architectural awards. I bet there are some.
Just on that, what's been really interesting is architects are a good example. The volunteers are another good example of actually giving people permission and to actually say, I want you to talk to this group and nothing's off nothing's off the table. I mean, clearly there's not a limitless pot of money to do anything, but actually people have really got excited about being told, yes, you can go and please go and talk to the people and design it with them. Because I think we probably don't normally work in that way. Normally it's stick to the brief and make it easy.
I think a lot of the problem is with accessible design is what is the legally required minimum is not a good enough standard for 99% of disabled people. So I think actually having these conversations with the architects and pointing out these things hopefully will make a big difference. But I mean, the motto of the disabled community is nothing about us without us. You would never think of running any other program or hospital or anything else for a group of people and not directly go to that group of people and find out what they need. So I feel like this actually addressed that.
Jim, please.
I think what you said, the three of you, was very heartening. I'm obviously an older person, so much of what you said there resonates with me. I was also for months blind in one eye. So to make a bad pun, I had to see the world quite differently. And the detail you've got there about signage, direction, movement, and so forth, actually, I think for many of us, will provide it once it's finished on page 58, ongoing, you need to come back on that once you pin things down. I think will make things much different. But I do know Imperial is very receptive. When it's trying to design a new St. Mary's, if it gets the money, it tried to bring in so many user groups, particularly older people, disabled groups, and people from other cultures who had different demands. And that changed, I think, how they saw a hospital. I'm just wondering about one thing, because Imperial is actually quite receptive. At the acute board in common, which takes place every 3 months, there's always a patient story. Sometimes it's a group patient. And what you've got, I think, will help open the doors for the decision makers to have to think differently about their institutions, because all of them have got building plans at the moment. You know what so many people need. They know about what people want, but that's a different matter. So I think it would be worth getting in touch with the acute board and saying, you actually experientially have something to give from which the hospital can learn, which can benefit a huge community, not just the disability community, which must come first, but wider cohorts.
I think the important thing to remember is accessible design benefits everyone. It doesn't just benefit the disabled. Stairs are evil. I'm not a big fan of them. But yeah, making these changes will benefit everyone and not just the disabled. And I think that is sometimes the thing we have to reiterate in getting people to part with money for things like sign language interpreters. It benefits everyone.
Thank you very much for those suggestions and recommendations, Jim. Councillor Sanderson, and then invite Councillor Painter.
Thank you, Chair. Just huge thank you to Jenny, Jack, Nikos, Victoria, the whole of AOD, and of course Imperial for all of the work on this. I think it's really restoring dignity. Oh my goodness, you okay? Thank you. I'm just going to pretend you're really moved by what I'm saying already. So thanks so much. Oh, also, just whilst I remember, there is currently a trip hazard here talking about trip hazards. So if anyone is coming through this way, just go around that way so we don't have our own problem here. I think really what you're doing at a point where people are incredibly vulnerable anyway, because they're going into hospital, it's restoring dignity and making something which is already hugely stressful and often quite upsetting, just as good as it can be. And of all buildings, a hospital absolutely should be one that is right for everyone. So thank you for all the work. Lots and lots of my questions have actually answered already. So how are disabled residents going to be involved in post-implementation user testing? But that sounds like that's going to happen through the volunteer programme. Lovely. Beyond physical access, what's the plan for systematic disability and neurodiversity awareness training? Great that that's all happening as well. And for deaf patients, will co-production be resourced and governed over time at Imperial so that it becomes part of BAU and not reliant on the goodwill of very wonderful people who are going to push it forward? And finally, just to build on Jim's point, what are the links between this and wider ICS priorities on equalities and access? And could elements of the Charing Cross model be spread to other imperial sites or across the whole of North West London in a dream scenario?
So I very consciously decided that we would just get on and do this. The timing was right. It was in response to something that had come through this committee, and it just felt right to see what can we do. I think your questions are pertinent. What do we do next? Because it has to be a more sustainable thing than enthusiastic people making it work. But I think to get it going, this was the right thing to do, to address the problems and actually say, let's all work together to just make something happen without having to go through the formal governance routes of committees, etc., etc. But I think in terms of going forwards now, I think it's something we need to talk about with the wider trust as to how we do it. The volunteers is a good example where that is already being spread, those ideas across the organisation. But yeah, we do need to make sure it's sustainable. And we go around the loop of making sure that it's not just good ideas, it actually changes what we do.
Thank you. And I just want to say thank you particularly to Jack for making that point around accessible design, making things better for everyone. I'm a frequent flyer at all of Imperial's hospitals, but frequently get lost. So look forward to the new signage. I just wanted to ask Jack and Jenny, I mean, the work that you did, particularly sort of going along to those meetings with AOD and with some of the other trustees and other residents, to sort of step back a little bit and think a bit more meta and what could be done to make that process for groups to come together even better for yourselves, for other trustees, for disabled residents. How I think it's really commendable for any patient or hospital user to talk so openly and candidly about their experiences and challenges that they face. And is there anything that could be done differently or done better to make or to invite more people to feel more comfortable to do the same?
To me, it's more to do with where do you start? How do you start? So if I wasn't a AOD user, I wouldn't be able to give that type of advice and support to Charing Cross. Yes, they have their own boards and people who say they are working for and who are disabled, but there's a whole range of disabilities that are not being covered. And that's starting from there is how many of those board members or panels have got a vast range of disabilities from the start. You might have one person who's a wheelchair user, but are they a manual user? Are they a wheelchair user who's in a tilt type wheelchair, which is a lot more bigger than the wheelchair here? I'm going into a wheelchair myself, so I am finding it rather difficult finding the right type of information myself. I like the idea of what Donna was saying, that it's very difficult. I'm under AJM at the moment, and they are absolutely horrendous to talk to. I can't get my foot in my door with them, and they are HRS is a wheelchair
private service that the wheelchair service has been
the NHS
in
use.
this area. Well, no, the whole of London.
Yeah.
Yeah.
So
AJM
Healthcare.
There was a Watchdog episode on them recently.
Yes. So if you start us at the beginning, where do we find the information? How can patients give that information. PALS, patient liaison service, you can give your feedback, but then it only goes that a little bit further. You need to start at the beginning, I would say. So that's how I would look upon things. I don't know how Jack looks upon things.
I completely agree with you. The only thing that I would add is that I feel like it is important to have someone like Matt who is willing that when people are as critical as I am, because I have the gold standard of accessibility in my head, and that is not affordable or something that we can have everywhere. So I think it's important that you listen to what we said, even when I was being particularly harsh. And we had good conversations on it and we moved forward with it, as opposed to feeling like we are writing a complaint into a PALS box that never gets read and nothing ever comes of it.
Okay, well, thank you so much. Again, to you for coming this evening, for your time and for sharing with members of HASPAC the second part of the project. Thank you for sharing as well the experiences, what has worked well, and some of the recommendations as well that we've heard this evening, and recommendations I think that are important for all of us to take on board and think about implementing these. Hopefully, this it will be embedded. I mean, eco-production could be embedded permanently into the trust. I know what you're saying, Matt, in terms of the initiative and the decision that you made to be part of this process, but hopefully we'll see a second part of it and embedding this in other aspects of the trust and ensure that this work continues beyond this individual project. So yes, we'll see. Thank you very much. I appreciate your time. And yes, thank you as well to Nick at the back, school production lead. Great. Okay, before we move on to the next agenda item, I would like to adjourn for a couple of minutes. Please. And be careful with the trip hazard as well. Thank you very much. Thank you. Okay, thank you. Okay, let's move on to our next agenda item. Agenda item number 7. I think it's page 66 of the report. The drug strategy. So who we have? Dr. Mayera Abdulhan.
Hi, thank you, Chair. I'll just introduce the strategy and my colleague Elizabeth will give the details. So we are pleased to bring this strategy before you. It has been a long, hard work went into the strategy by my predecessor, Dr. Lang, Elizabeth Eagle, and colleagues across enforcement, community safety, prevention, early detection, treatment, recovery, and people with lived experience. So true co-production went into this strategy. Before I hand in to Liz, I'd just like to highlight that the next steps, once the strategy is approved, is to develop a system-wide action plan detailing which organization will be responsible for doing what. And then the Combating Drugs and Alcohol Partnership Board will be responsible for overseeing the implementation of the strategy. Over to you, Liz.
Thank you. Thank you, and very nice to meet you all, and nice to meet you, Chair. I'm Liz Eagle, Substance Misuse and Suicide Prevention Lead based within Public Health. So as Maya's rightly said, we're presenting the local drug strategy here today for the committee to adopt the strategy across all wards, and what we hope is to use this as a way of enabling a more coordinated approach to tackling drug-related challenges. We know that there are lots of issues around drug and alcohol related harms in different communities. And we know that there are different individuals that present in different ways, whether it's in relation to co-occurring mental health and substance use, whether it's in relation to substance misuse as a homeless health need. We recognise that there are risk factors affecting people in different ways, depending on their background, depending on their support needs. So what we're really aiming to do with this drug strategy is to try to enhance support for as many people as possible using substances in Hammersmith and Fulham. We're trying to reach more people in the community as well, because we recognise that there are high percentages of people who actually aren't in treatment, and that risk is higher for people using opiates as well. So we're really trying to meet all the different gaps in support, the different gaps in harm reduction that we've been able to ascertain from the research that's been done to feed into this strategy, from the conversations that have been carried out with different professionals and with residents engaging in substance misuse services as well. So we feel that we've put together quite a detailed and robust drug strategy, which in itself has had different iterations, and we've worked towards this current iteration to really try to ensure that it's purposeful, it meets and aligns with national strategic ambitions, and really understands our local issues and how we can work towards rectifying and really be more action focused around drug and alcohol related harms. So in terms of the background and overview of the strategy, this just highlights some of the key statistics that we have locally. For example, around drug-related offences. In 2024, there were 1,035 drug-related offences, which is incredibly high and an 11% increase from the previous year. And the drug offences and the rate that's just been mentioned ranks us as 6th amongst London boroughs for drug offence rates, which isn't a status that we want to maintain. We absolutely are committed to working hard to changing that. In terms of community complaints, there were 121 CACUD addresses, 49 drug-related complaints and 100 antisocial behaviour complaints, which were reported in the same time period. And one of the key values of this strategy are that there's a good balance between enforcement ambitions and actions and public health ambitions and actions, because we really understand the fact that drug and alcohol needs aren't just health-based and health-focused. They have wider impacts across the society, and they have wider impacts on residents who unfortunately are going, you know, by their day-to-day business and may be accosted by somebody undertaking acquisitive crime. They may be impacted in other ways by seeing other issues in relation to drug-related harms. So we're really trying to address that and ensure that we maintain a balance between public health and healthcare, and trying to improve support for people accessing support, but also maintaining the fact that there are wider impacts that we really must address, because drug-related issues affect all of us. The number of people in treatment is something that we've worked incredibly hard to address. So we've been able to increase the numbers in drug treatment by 22% since 2021, which we are incredibly proud of, because it's a figure that's actually higher than regional patterns, but we definitely recognise that there are more in the community to engage. And alongside that, we've also worked to enhance our workforce. We've worked using the NHS workforce strategy, and we've really understood that if we have more people in treatment, we need quality staff to support them. We need more people working to help them achieve their outcomes. So we've been able to look at the spectrum of the workforce services across our treatment systems and see, do we need more mental health input? Do we need more specialist key workers? Do we need more specialist roles that can really support people around some of the dualities of substance misuse and the co-occurring needs around physical health, mental health issues, around the different other factors that they may present with? And that's what we've been able to do through the increase of the workforce. We've also focused around drug and alcohol related deaths. So our 2021 to 2023 mortality rate per 100,000 showed us at 11.3 per 100,000, higher than London and England at the time. We've worked to reduce this significantly, and recent figures do show that we're in the right direction. So they do suggest a reduction to 7.6 per 100,000 across 2022 to 24. However, again, the work remains to better align with regional levels, which are at 6.4 per 100,000. So we've developed a drug and alcohol related deaths panel, which really supports us in understanding some of the trends and the learning from each individual case, and makes sure that as a partnership, we're working hard so that we're learning from absolutely every single death. And there's a further mention around co-occurring substance use and mental health, which I won't repeat because that's already been mentioned. So in relation to a further summary of the strategy, at a foundational level, the strategy is underpinned by the National Drug Strategy, From Harm to Hope, a 10-year drug plan to cut crime and save lives. And again, that's well aligned to the report that was completed by Dame Carol Black, which showed and found that there needed to be a better balance between substance use and enforcement, and between public health approaches and enforcement. So really trying to ensure that we're not just focusing on one or the other. There are wider impacts. So the recommendations from the National Drug Strategy have enabled developments such as the Project Adder scheme, which is overseen by the Metropolitan Police, which is an incredibly successful diversionary approach to ensure that people aren't just seen as causing offences in the community. If they need support and they need treatment, there's a way of officers getting them to access treatment. And there's a stronger partnership between the Metropolitan Police and our substance use services as a result of that. And in terms of other work undertaken around some of the foundational aspects, and by the Combating Drugs and Alcohol Partnership, we've also worked to increase investment in our treatment services. As I mentioned, we strengthened our collaborative approach. So there are joint actions between the council, police, prosecution services, in our ambitions to meet our 3 different themes. So these 3 themes align with the national drug strategy, but locally we're proposing to adopt them, and we're proposing to ensure that we have local actions and ambitions aligned to each. So the themes include breaking drug supply chains, very much an enforcement approach, world-class treatment services. So we're really hoping to treat addiction as a health problem, recognising the role played by adverse personal circumstances such as trauma, poverty, mental health conditions. There are backgrounds and bases for why people use substances, and there are schools of thought that anybody can and is affected by substance use in one way, shape or form, whether the people in their lives, in their circles disclose or not. So we need to work hard to ensure that there's better support for people when they need support. And we need to work to break down the stigma and save lives. There's an anti-stigma campaign that's overseen by lots of substance use services. So we're really looking at some of the learning from more national approaches like that, and seeing how we can adopt certain things locally in Hammersmith and Fulham so we continue a culture of learning. And thirdly, we will look at achieving a generational shift in the demand for drugs. So included in that is our approach to supporting young people. We want to stop the use before it starts, and that's an absolute priority for us. So we're going to look at how we approach the work around schools, how we support young people who may be engaged with youth justice, how we really try to break the cycle of substance use for people who may have started using substances and already may not see a way out, or for people that may be surrounded by substances through parents, so parental substance misuse, and again, may see that as a normalised approach to coping with life difficulties. So we're trying to work hard to ensure that that is addressed as a partnership. And in terms of further overviews of the strategy, it includes consideration around emerging threats and trends such as cocooing, synthetic opioids, which is an incredibly growing concern, and chemsex. So as has already been mentioned today, we're doing a lot of work around trying to really understand the prevalence of chemsex locally. We're not dissimilar to other local authorities in other areas in that the prevalence is ill understood across the country. So we're working with specialist and expert services such as London Friend, who themselves have completed lots of research into the area to really try to understand the approaches to supporting people engaging in chemsex, because there is no one size fits all, and we need to know what's going on for our local residents. They're working with sexual health partners and treatment providers to really try to see how can we enhance support for people who may be engaging in chemsex, where we know that the risks are incredibly high, both in terms of substance misuse, in terms of sexual health, in terms of consent, in terms of potential criminality. So there are lots of different complexities that we're really trying to explore with that. And in relation to a more responsive approach, we're looking to ensure that we evolve with the growing trends, as has been mentioned, but we remain relevant. So again, there are other things that we recognise are becoming even more concerning, but for particular groups, such as ketamine for young people. So there's recently been some information that's been circulated around how to ensure that there's more awareness. So we're really looking at how we widen that information, but we're looking at building our ketamine approach. We've got our services linked and developing ketamine clinics in local hospitals. We've got our services really trying to understand, again, why people may use certain substances, in particular, what the drivers are, and trying to see the patterns and trends in different substances, because there are certain groups that are using more substances now of a particular kind, such as young people using ketamine over cocaine, and other groups using other things over others. So we're trying to understand the intricacies for different groups and how we can support them adequately and to a high standard. And again, lived experience being at the core of this, we've really tried to ensure that this is absolutely trailed through every inch of the drug strategy. And we have devised an action plan to absolutely evidence that what we are going to do, what we are committing to do, will work. And if there are things that aren't working, we are committed to changing our approach to ensure that we show action and we show outcomes, because for a long time there have been concerns and things and issues that residents have raised, and we're using this as a way of hearing them, and we've devised something that really supports the community in making the changes needed. And this just provides an overview of how it aligns with our local values and corporate plan, and it includes putting the residents at the centre of their own care, but also recognising the harms to the wider community. And there are further mentions in here around what's already been referenced in relation to the voices of the local residents, and the strategy being promoting quality, sustainable support options for people, which is absolutely key and at the centre of this. So in relation to our ambitions and what we hope to achieve through this strategy, and using our Combating Drugs and Alcohol partnership as a driver for this, we are aiming to break the drug supply chains by increasing engagement in drug treatment, but also by looking at specifically reducing drug-related harms, looking at diversionary approaches, looking at criminal justice approaches that work alongside public health, deliver a world-class treatment and recovery system. So looking at developing really key things and a different approach, such as creating our own local lived experience recovery organisation, making sure that recovery support is increased and enhanced across Hammersmith and Fulham. So there should be something that people can access on their doorstep if they need to go to a mutual aid meeting, if they need to access a smart recovery meeting, which are all mutual aid services. So it's really important that people have easy access to recovery and support, and we're making the lived experience voice louder in the community. And we want to achieve a generational shift in the demand for drugs, and that includes doing lots of different things around enhancing peer mentoring and support, and making sure that people can see what recovery looks like. And this just provides a visual of our Combating Drugs and Alcohol partnership and some of the subgroups that underpins that. So our CDAP includes involvement from public health, probation, VCS services, our treatment and recovery organisations, NHS partners, DWP and other specialist partners. And in terms of some of the subgroups, just to focus on that briefly, if I may, our Combating Drugs and Alcohol partnership has quite a large and wide-ranging development plan, which supports us in maintaining some of those strategic actions and ambitions. And within that, we have different subgroups which themselves have action plans that really drive forward the work that we're trying to do. And that includes a harm reduction forum, so specifically targeting on drug-related harms, whether it's naloxone and how widespread and accessible that is across the community, whether it's needle exchange, and again, how accessible that is, whether it's making sure that we're reducing the harms around chemsex, looking at other specific issues affecting the community. So that forum is incredibly key and will support us in the work that we're trying to achieve. We've also got our lived experience recovery group. So what we hope to do at a later point, obviously, depending on how the strategy is adopted by the committee and through the governance measures, is to share the drug strategy with the lived experience recovery group and with our lived experience and living experience residents across the borough to get their feedback on it and to really ensure that, again, this is purposeful for them. And we have our drug and alcohol related deaths panel, our individual placement and support group, because we want this to be a really positive approach and a change in approach to substance misuse. So the IPS working group supports people with employment ambitions, and we want to really closely monitor that to make sure that people have things to do and employment to access that really helps them get involved in meaningful employment, meaningful activities as well. And we have our local drug information system, which specifically focuses around drug-related harms, but potentially of unadulterated nature. So looking at some of those risks around synthetic opioids, looking at concerning drug-related trends where there have been particular incidents in neighbouring boroughs or in our own borough. Luckily, we haven't necessarily had to raise a drug alert in the recent year. However, it's still, of course, a concern that we remain very mindful of. And we have our Street Population Action Partnership, which is in collaboration with our community safety team. And in terms of the Combating Drugs and Alcohol Partnership, the CDAP remains accountable to the Community Safety Partnership, to the Office for Health Improvement and Disparities, and other multi-agency forums. And that includes as well some forums focused around VORG and other difficulties that may affect particular groups where substance misuse is a co-occurring risk factor. And the Combating Drugs and Alcohol Partnership actions will also remain connected to the Community Safety Plan and other priorities across the borough, including the Serious Violence Duty. And lastly, any questions? Thank you.
And thank you so much, Elizabeth, for that very thorough data presentation. It's really very interesting, very informative as well. I know the amount of work that has this process has involved, and the different partners as well that are part of this partnership as well, and the ambitions that you have. So, and the vision as well. So it's very positive, the strategy in place. Do you have any comments, questions? Yeah. Jim, and then we've got Councillor Kwan, and then Councillor Bonner. Thank you.
I think an immense amount of work has gone into this. It's both distressing to read, but it's also very heartening to see what you're planning to do. I'm curious about generational shift because I worked in schooling. What you're doing is so comprehensive. Have you thought about how to bring it into secondary schools or into West London College? Because the way of reaching out to younger people before they get stuck in patterns which are very difficult to break, information is key. And I'm just wondering whether you've thought of using the borough's youth parliament as well as a forum where the kind of issues you've talked about so well can actually be discussed in terms of how to change things.
Thank you so much for that question, Jim. So yes to both of those things. As part of the development of the strategy, we engaged with the Youth Council, and the recommendations that they made have been embedded into the drug strategy. And again, we hope to go back to them with a more final version of it to ensure that their voices were definitely heard in that. In relation to schools, that's been an evolving piece of work. We have definitely been trying to engage with schools, and we've worked with our schools engagements lead within the council. We've also been working with children's services. We have a specialist substance misuse lead within the public health team, specifically focused on children and young people, who is really working to drive this work forward. He has his own plans that he's working to in terms of making sure that we're increasing the support for young people. We've also focused on doing a piece of work around the schools exclusions list. So making sure that people aren't just excluded without actually referral to support services, because we know that when young people are using substances, and when they're using substances to some of the concerning levels that they may be using where treatment is needed, they need support rather than to just be excluded. So that's a piece of work that we're undertaking and will remain committed to doing, to ensure that, again, we break the cycle and we really try to make sure that these young people have better outcomes in life, and you know, they may go on to fulfill more things in their lives, and hopefully don't get derailed to a certain extent by substance use. Thank you. Thank you.
Sorry, I'm sort of acutely aware this is my first appearance before this attending, because I've just come back off medical leave. From my understanding, this paper was on the agenda for the Policy and Oversight Board at some point, but then it seemed to drop off when I looked through the past meeting notes. Is because of the sort of cross departments, obviously, that this strategy touches on, is that going before that board, or is it sort of, was it distributed to the other PAC chairs? Do we know?
So I think it would, because it's a public health strategy, would come here for oversight first, before it went more broadly.
Okay, so yeah, just obviously because the issue crosses over into different, particularly community safety, but all sorts of other ones. I'm sure the other PAC chairs would be interested in seeing, sort of, because there'll be crossovers, and I'm sure it comes up as well. Yeah, well, if we can make sure that it gets distributed to them and they know that it's going forward.
Thank you. Yes, we will. We want to take this as many places as we can to ensure that we get it right, and we recognise the crossovers. So yes, we will do what we need to.
Thank you. Although I think what we just wanted to highlight really with this paper, that we want to take a kind of Glasgow model public health first approach as opposed to community safety and enforcement approach, because although compassion and enforcement aren't direct opposites, we need both to protect residents. This is primarily a public health issue, and that's how we want to approach it here, as opposed to quite a heavy-handed enforcement approach, although that obviously does play a role. So that's why it's coming through this journey first.
Thank you, Councillor Buller.
Thank you for that. I wanted if you could tell me a bit more about the kind of approach to cuckooing. Obviously, it's something that's growing all around the country. I wasn't aware that it was quite so prevalent in Hammersmith and Fulham, but obviously it goes on all the time behind closed doors. You don't know what's happening. And of course, it's taking advantage of kind of often the most vulnerable people in our communities. And anything that we can do to disrupt the actual trade. You know, I think most people know that drugs are bad. It's trying to, obviously, it's multifaceted reasons why people are taking them, but if we can in any way kind of disrupt how easy it is, maybe is that what you're looking at by trying to disrupt cuckooing and things?
So that's definitely one of the aims, but we're looking to enhance the work that's already been undertaken. So we've got a well-established cuckooing risk panel, which is overseen by the antisocial behaviour team in conjunction with Metropolitan Police and other services, including treatment providers. So one of the key things that we've actually trialled, and it's started very recently, is to look at embedding a substance misuse worker within the cuckooing team, and looking at building support and specialism from the inside out. So making sure that that worker supports the team around recognising substance misuse related risks and harms, making sure people have access to support, both from a victim and a perpetrator perspective, but also ensuring that, again, we have that balance between enforcement and public health, because cuckooing doesn't just happen again. There may be individuals or dealers invited into a property initially, and then things change, or there may be a level of desperation or vulnerability that drives certain things and issues in relation to that, because and of course we know that there are significant vulnerabilities in terms of substance misuse that certain people unfortunately may take advantage of. So we're trying to ensure that we're looking at it from a multifaceted approach, from a safeguarding approach. So the Cuckooing Risk Panel sits as part of the safeguarding framework within Hammersmith and Fulham, but also recognising the enforcement and public health needs within that as well.
But incredibly complex and difficult issues, so thank you for the work that you're doing on.
Thank you very much. I've got a question. How will success be measured across treatment and prevention?
So there are lots of different metrics that have been put together in relation to that. So ranging from more quantitative things like increasing numbers in treatment, increasing the number of treatment starts, making sure that we have increased access to detox and rehab. So looking at the more quality aspects. So it's not just a case of getting people through the door and keeping them in treatment, so treatment retention, but also looking at what they're doing whilst they're in there, because we want treatment to be as successful as possible, and ensuring that they're engaging with recovery support services, making sure that we've got all of that, all of those considerations included, because we want to make key working a lot more quality, and we can't have people, unfortunately, staying in treatment and stagnating. We really want them to achieve the outcomes that they're hoping to achieve. So we've really worked to, again, look at that that action plan and ensure that the actions that we've developed are reasonable, are measurable, and most importantly, are achievable and can be evidenced.
Thank you very much. I know there was a member of the public that had their hand up. Would you mind coming to the front, please, and introducing yourself?
Yeah. Is that fine?
Yeah.
I'm also interested in the generational shift in seeking drugs, and particularly what you said about the school exclusion list. So where would these students, when they're excluded, where would they be sent to access support? Are there particular places or systems?
Yes.
Oh, sorry.
Yes,
I'm
please.
Laura. I live in the area. I'm a student journalist. I'm just interested in the topic.
Thank you.
Thank you, Laura. So we have a young people's drug and alcohol support service called Resilience, which is run by Turning Point. And they provide specialist support for young people who may have substance misuse needs, but they're also well linked to other services, whether it's West London Trust and their CAM service. They're also linked to Youth Justice, and the YAP service that West London Trust again oversees in terms of their young adults provision. So we try to ensure that they remain, they keep their ears to the ground as much as possible and understand some of those emerging trends, some of the language associated. We all know that the lingo in terms of young people, the language being used on social media. I mean, I may not be able to say much of it myself, but that's why Resilience is there. So they really work hard to support our young people locally and to ensure that they're increasing the number of people that are aware of their service and know to turn to them in times of need.
Sorry. And so is resilience associated with the school? Do they work together, or are you guys kind of in between that point for students?
So resilience are commissioned by Public Health, and they do have workers who provide support to schools. They ensure that when they have young people engaging with their services, they know as much about them as possible. They form part of professionals meetings. If there's a child going through child protection proceedings, then they ensure that they work with schools within that structured framework as much as is needed. So they definitely try to ensure that there's a collaborative approach, and working with schools forms part of that.
Thank you very much. Thank you, Lara. Thank you for your interest and the question, and thank you, Elizabeth. Are there further questions, comments? Councillor Sanderson?
Thank you. I promise there'll be nothing from me after this. Oh, no, there will be. Sorry. No. Nearly done with me. Just to say, obviously, any addiction-related death is a tragedy and one death too many, and our drug-related death rate is too high. So the strategy, I think, is the strongest partnership plan that we've ever had, bringing together treatment, mental health, harm reduction, early help enforcement in a way that is genuinely joined up, and something I don't think we've really had before. The priority is really simple, so fewer deaths, less exploitation, and better help for people before crisis hits, instead of right at the end when things are incredibly difficult to manage. We want a really clear downward trajectory in drug and alcohol-related deaths, and that's our top shared outcome, and it really cannot be delivered by us alone. And so every partner, the NHS, police, probation, and our voluntary sector holds real accountability for this, and we are working alongside them to deliver this. And just say recovery is absolutely possible and already happening locally, but we need to widen access, strip away stigma, and make pathways faster and much, much more humane, and that is what this strategy sets out to do.
Thank you very much. Thank you for that summary. Oh, yes, sorry. Please go ahead.
Just got a quick question about your complex needs. How many of those complex needs are disabled residents?
I won't be able to say that at this very point, but we can definitely look into that and speak to that at a later point. What I will say is when people are accessing services, they are supported in completing a comprehensive assessment, and that includes all of their health and physical needs, or as much of that obviously is possible to capture. And there are psychiatrists and psychologists within the service. There are clinical teams, including nurses as well. There are mental health nurses and RGNs within our services. So we try to ensure that as much as possible, whatever the needs are from the comprehensive assessment, a support package, a care plan is put together that aligns with that.
Following on from that, I'm talking about residents who have got a addiction to drugs, who are possibly wheelchair bound because of it. Could be because of their mental health, like ADHD and things like that. So where it says complex needs, I think you need to be a bit more broader to actually say what type of complex needs are you covering, because it could be because they've lost a limb and their mental health has gone downhill. They've gone to drugs for a type of therapy type thing. So these are the types of things that may be a good idea to look into, and especially when it comes to cuckooing. And cuckooing is not just for drugs, it can be financial gains as well. So that's something to be a bit more broader as well to have a look at. Thank you.
Thank you. I think those are all really, really good points. And we know that we're already dealing with something that's deeply complex, because addiction is deeply complex. And so then you add on all the different layers of vulnerability. You're right, we need to be really explicit. I think we know that disabled people face unique risks, but there are also lots of other pools within that. So women, LGBT plus community, sex workers will all have really complex needs and approaches when it comes to addiction. So I think it's really incumbent on us and really important that we make sure we have an offer that meets all of those needs safely and is really comprehensive. So thank you so much for raising it.
Okay, well, thank you so much again for the report, and thank you for your questions and comments and suggestions, which I think we noted. Let's also, as an action, follow up with the request that Councillor Korn has made to distribute the strategy with other chairs of other scrutiny committees, and we'll follow up to see if it's going to go to Policy and Oversight Board. Thank you for that. Before, let's move on then to the next agenda item number 8. I would like to please draw your attention to some workshops that are going to be happening as part of the Hammersmith and Fulham Dementia Action Alliance. I know we've got some information that we can put on the screen. So I had a request that we raise awareness about these workshops. Let's wait a second to see if it's, sorry about that. Oh, it's gone. Healthy Minds Together. There are some workshops for Hammersmith and Fulham residents 50 years and above. Do you have questions about changing your lifestyle to promote healthy brain aging? Do you want to learn about how to reduce the risks of dementia? So some workshops are going to be happening from Tuesday, the 4th of November until July 2026. If you're interested, or anybody watching is interested, please sign up, and there's a QR code for further information. Okay. Thank you very much. Councillor Sanderson.
Thank you. And I promise this is genuinely the last time I'm going to speak.
No problem at all.
Just wanted to welcome Dr. Maya Abuafan. Really, really delighted to have you here. So thank you so much for joining. But also, sadly, we are saying goodbye to Catherine because it's her last meeting this evening. So just wanted to say thank you so much, Catherine. You really stepped in when we needed you most. You have been brilliant to work for. You have handled everything with grace and dignity and been such a constant source of support. So thank you so much for everything, and you will be much missed.
Thank you very much, Catherine Treco, Councillor Sanderson, and for all your contributions and expertise shared at hashtag. Thank you for that. Thank you, and wish you all the best. Next chapter. Okay, so our next meeting is happening the 27th of January 2026. So as this is our last meeting of 2025, I want to wish you all a good end of year and a prosperous 2026. Yes. Thank you.